right, hello. Welcome everyone to our webinar today on the role of community health workers. We have some great speakers for you lined up today. And this webinar is being presented by the South Dakota Department of Health and the South Dakota Cardiovascular Collaborative in partnership with the Patient Navigator Training Collaborative located at the Colorado School of Public Health, University of Colorado, Denver. And I'm Erin Martinez, the manager of the Training Collaborative, and I'll be your facilitator today. We are going to get started with our speakers today. First, we'll welcome Kylie Hump, who is the administrator of the Office of Chronic Disease Prevention and Health Promotion within the South Dakota Department of Health, and she's had this role for 3 years. She has been involved with various community health worker work groups that have taken place for the last 3 years, and she will share some more about that with us today. With that, I will hand it over to Kylie. Welcome.
Good morning, everyone. I'm going to pull up my slides here really quick. All right. So good afternoon, everyone, and thank you for joining today's webinar. It is really the first step that the Department of Health is taking to educate on the community health worker role here in South Dakota. So today I'm here just really to give that overview of the various steps that have taken place here in South Dakota to advance community health workers over the last 4 years. And so what you see here is the timeline of those various steps that have taken place. And so really it started back in the fall of 2015 when our previous governor, Dennis Dugard, convened the South Dakota Healthcare Solutions Coalition and tasked them with the development of a solution that supports increased access to healthcare for the American Indian population and to help improve health outcomes for that population. And so one of the recommendations that came out of that work group is to develop a community health worker, community health representatives, which is another term that is used for this role within our tribal areas. And so, and to formulate a plan for reimbursement through our Medicaid state plan. And so the next step here is to help the Medicaid state plan in rolling out that reimbursement model. The Department of Health co-chaired a statewide work group with the Medicaid program, which involved various partners from different organizations like healthcare, public health, Indian health services, tribal health programs, that were tasked with developing a summary and recommendations document. And so that group really looked at national resources, reports, studies that have been done, also understanding what was happening with our community health representatives here in South Dakota, which have been in place for over 50 years. And so learning from them on what that role and the types of services that they can provide and the types of skills that they have. So we really, within that recommendations report, we looked at scope of practice. So those types of services that they would be looked to providing, like resource coordination, coaching, support, group education, and providing that cultural appropriate health information to various group populations. And then they also looked at core competencies, and so those skills that someone within this role should have, demonstrating competency in motivational interviewing, demonstrating cultural competency, understanding different community resources that are available. And then the other component to that recommendations report was looking at education and training. And so they looked at other states' curriculum, some of which you will hear from today, and looking at, what they have in place to start educating these individuals on, developing those skills and those competencies to be successful in this role. And then the third step here is the actual implementation of the community health worker reimbursement model within the state Medicaid program. And I'm excited to announce that it was rolled out on April 1st of this year. And so that is currently available. And I will say, you can find more information on their website, which is dss.sd.gov, for more details. We also plan to do a follow-up webinar to this in working in partnership with our state Medicaid program to go into more detail about what that reimbursement model looks like and some of those details of how to go about enrolling within the Medicaid program and reimbursing for those different services. And then the fourth bullet here, I just wanted to bring awareness of some education and training that is currently in place for community health workers within our state. And so the Indian Health Service, like I said, has a long-standing community health representative program, and they have a very comprehensive curriculum. And so, that's definitely a curriculum that we're promoting and encourage folks to take advantage of. And we also have had conversations with Lake Area Technical Institute, their 2-year university, and have gotten approved through the Board of Technical Education to offer a community health worker program at their school. They have both a 6-month, 1-year, and 2-year program, and they're launching that program fall of this year. So another great opportunity for if you have current staff that are interested, or if you know of someone within your community that might be interested, that's a great opportunity to get the appropriate training that you need. And then also this morning, I just wanted to give a preview of some of the work that is currently happening within various programs within the Department of Health around community health workers. And so through the Cardiovascular Collaborative, which is a statewide stakeholder group with the mission to improve quality of health of all South Dakotans through prevention and control of heart disease and stroke. And so they, I have had the pleasure of leading the Goal 2 work group, which is focused on looking at priority populations and helping them decrease heart disease and stroke within various population groups. And one of the priority strategies over this last 6 months to a year was looking at community health workers and the role that they can play in heart disease and stroke. And so today is our first step with this webinar to start educating healthcare providers and facilities about the CHW role and what that could look like within your organization. We're also in the final stages of a promotional document that will be a print resource available on our website that really defines what a community health worker is, the role that they can play, how it could benefit your organization. And we also highlight a success story even that is happening here in South Dakota of how they've utilized a community health worker and the health outcomes that they're receiving with some of their patients that CHW is serving. And so a lot of great resources that will be available here soon to start the conversation within your facility and other providers about this role and how they can benefit you and your patient. And so more to come on that. We also, through talking with a small amount of healthcare providers, one of the things that came up was looking at some assistance around the hiring process of a CHW. And so we're looking at developing a toolkit, a packet, or just a few resources pulled together that can help those providers, those facilities to be looking at how do I go about hiring a CHW? What could that look like? I feel like, this really is a different type of profession that more than likely won't have, letters behind their name, a standard training. It may look really different depending on what your needs are for your facility and for your patients and what type of level of education that you're needing to perform those different roles. Also, I will mention through our heart disease and stroke program and diabetes programs through federal funding that we receive, there's a strong emphasis on community health workers and the role that they can play in reducing heart disease, stroke, and diabetes. And so We're going to be looking at also providing some ongoing training, particularly around those chronic conditions, but also looking at others and how we can support CHWs and the different roles that they could play if they're going to be working more with diabetes patients, providing that ongoing training for them to learn more about that disease. And so really looking at that's our role as the Department of Health, that we can provide that additional training for them. And also we know for sustainability for CHWs and for them to learn from each other and think to support each other in the work that they're doing, we're looking at starting a statewide alliance, coalition for them to come together and meet each other and hear about the type of work that they're doing and hear their needs, if there's additional training needs they need or resources that would help them in the work that they're doing. So we think that that's a really important thing to be looking at as we're starting to build up this profession here in South Dakota. So I'll close and just thanking you guys again and excited about hearing more on this webinar about what other states are doing and just really getting the conversation going here in South Dakota.
Perfect. Thank you, Kylie. Next, we have Patricia Valverde, who's an instructor in the Community and Behavioral Health Department in the Colorado School of Public Health. Dr. Valverde has developed curriculum for several Patient Navigator projects, including the National American Cancer Society Patient Navigator Research Project Training Program and the Community College of Denver Community Health Worker Training Program. And she is currently the director of the Patient Navigator Training Collaborative, which is a training program for patient navigators, care coordinators, and community health workers. All right.
Great, thank you so much, Erin. All right, so what I will be talking about is a little bit of the history and role of CHWs. We'll discuss how CHWs are part of or can be part of a care team, and what are the competencies and skills required for individuals to conduct that role. I will start out with history and role, and I wanted to mention that I have links on almost all of the slides, as well as additional slides at the end that I won't review that include resources. So I really encourage you to go into the slide deck when you receive it if you want to look at the source material. So the use of lay or community members in trying to extend healthcare access is not new. As you can see in this slide, we have early examples of lay health workers going back hundreds of years in Russia and then in China with the barefoot doctors. But the use of community health workers really gained traction in the 1960s. In Latin America, there was a movement around empowerment and individuals being able to take control and be involved in their health, and that led to the role of the promotores de salud. And in the US, community health workers and lay health workers began being used to assist migrant workers around their health issues and in Indian health services. So as Kylie mentioned, IHS has been utilizing these kind of paraprofessionals or lay health workers for many, many decades. It wasn't until the late 1970s when the World Health Organization began to define the CHW. And what you'll see is a definition that's quite different than how we view CHWs here in the US. The WHO suggested that CHWs are employed by the communities that they serve. They report to the communities. Whereas in the US, they tend to be either part of community organizations or healthcare systems. In the early 2000s, there was the advent of the patient navigation role or function. And so what we saw over the past 20 years is the adoption or integration of system navigation into the community health worker role in the US. So there has been a recent report through a project called the Core Consensus, or C3, and they've updated the role of the CHW based on current literature and reports and surveys. But the CHW continues to have a primary function as that cultural mediator between a community that's vulnerable or underserved and the healthcare system. And being a cultural liaison allows them to provide culturally appropriate education and information. And then more recently, like I had mentioned, we see that community health workers are often not only connecting community members to healthcare systems, but then involved in navigating them through a healthcare system with care coordination and case management. Community health workers historically have served at the individual level and the community level to assist with advocacy, capacity building, and conducting assessments. And also CHWs have been very involved more recently in coaching around health behavior change for chronic disease, self-management, and providing social support. Some provide direct services, so there have been many interventions with using CHWs doing blood pressure monitoring at community sites. Historically, CHWs have been widely used for outreach, and then more recently, evaluation and research. So I've worked a lot with community health centers, and with the advent of the Affordable Care Act, there's this expectation of outreach and enabling services. And they're basically non-clinical services that are important in order to address healthcare access issues and poor health outcomes. And if you look at the types of enabling services available, you'll see that they mirror very well what a community health worker can do. So it ranges from assessing social needs to providing transportation and health education and navigation, among others. Now, we know that across the country there is a big problem with titles, and I encourage you not to worry so much about the position title, but really focus on the function, especially when CHWs or lay health workers are working within a team-based care setting. The scope of work is extremely important. So what is the CHW able to do and going to do versus other members of the healthcare team, and also integrating their role in workflows. So we are moving towards scheduling preventive care visits and visits that allow for focusing on chronic disease self-management support. And the model that I'm showing you here is for self-management support. And the idea is it extends the reach of the clinic to the patient to include before the visit. And that might mean conducting some needs assessment or working around medication. During the visit, where there's coaching and support and building an action plan. And after the visit, where the healthcare team is connecting the patient to peer programs, resources, and conducting follow-up. So the community health worker can be involved in all of these aspects of self-management support at the primary care site. Now, the biggest issue is typically, what can a lay person or an unlicensed person do? And so without very clear guidance at the state level in terms of the role and function, we often have to look at what are the delegation rules. And the delegation principles are typically the task, the circumstance, the person, directions and communication, supervision and evaluation. And I included the South Dakota rules around delegating. So I tend to think about, does the activity that you're considering for a community health worker, does it require licensure? And if it does, then you follow the delegation rules. If it doesn't, then I think through what is the critical thinking required for the activity. And I'll walk you through this. So for example, if all you want is someone to do reminder calls, that can usually be done with some supervision. But if you want them to do reminder calls and also a needs assessment, they probably need some decision aids, a script, maybe some protocols. But if you also want them to then refer to resources, then they might need more training around what are the resources in the community, what is the appropriate referral mechanism. And so community health workers, as well as other unlicensed staff, can be used in many different activities with the appropriate supervision, tools, and trainings. So the Core Consensus Project has developed recommendations for training of CHWs, and you'll see that it ranges from communication skills all the way through to knowledge base. And Riley had mentioned some disease-specific modules, for example, on diabetes, and that is exactly what is needed in order to be able to do many of the activities that require some level of decision-making. But other types of training is needed for if the community health worker is going to work on capacity building among patients and community members. Some states have outlined exactly what the competencies are for CHWs. They mirror nicely to the C3 project, but competencies might be around outreach and outreach methods and strategies, and going on to professional skills and conduct. So in conclusion, you have to be very clear about the scope of practice for CHW. I encourage you not to be, to provide sufficient organizational support for a community health worker to work at the top of their knowledge and skills, and also to help the other healthcare team members work at the top of their license. Sure. The CHWs are really important in terms of cultural mediation between the health system and underserved communities. We see that historically they've worked both at the individual and the community level. And now community health workers are widely used to not only navigate people to a healthcare system for preventive care or acute care, but also through the healthcare system. And both of those require, different skills and knowledge. They have always provided emotional support and logistical support. They are very effective at both individual and community level educational interventions. However, community health workers do need training and need organizational support given their licensure status. However, with job aids, decision guides, clear workflows, they can be a very, very robust member of the healthcare team. I mentioned that I included a number of resources. So there are a variety of community health worker toolkits out there. Also related to team-based care, there are a number of resources that can help integrating an unlicensed person into the healthcare team and for them to be able to take on duties that probably previously was done by a nurse. There's a variety of resources and toolkits out there. There are screening tools available and for social determinants of health. And there are a number of online modules also available for self-care management, and you'll see at the bottom it says the layperson. So there is a lot out there. I encourage you to take a look and see what we have around the country. And with that, I will close.
All right, thank you, Patty. Just a reminder to all our attendees that feel free to type in questions using that Q&A. It's at the bottom toolbar, and you can type in your thoughts, and we'll make sure to address those. And again, a reminder that we will make these slides available so that you can check out all those great tools that Patty mentioned on your own. Right. So let me take a moment to pull up our next presentation. Okay, with this, I would like to welcome Julie Beaubien, who has been at Children's Hospital Colorado for 6 years as a community health manager. In this role, she is responsible for the annual community benefit reporting to the IRS for the hospital system, along with conducting the community health needs assessment every 3 years. So in 2016, she was asked to develop a community health navigation team, and she's going to share a little bit more about her efforts with us today. Welcome, Julie.
Hi, good afternoon. So first slide, Erin. Erin's navigating the slides right there. And this slide seems really basic probably to our public health partners, but I think it's important to understand the challenges we faced and the progress we're making in medical settings for the medical community to understand or acknowledge that healthcare or health is only a small part of the total health picture. There's so many other things contributing to health, and I think it's been a real cultural shift here, at least at Children's Hospital, to start integrating social determinants of health into the understanding of what health is. And as Kylie pointed out earlier, a lot of navigation teams are focused on disease conditions. How can they work with families on asthma, cardiovascular disease, diabetes? Our model is strictly looking at addressing social determinants of health as part of the healthcare picture. So, next slide, Erin, thank you. So we started out in 2016 with 3 distinct projects. One, looking at ED utilization. How can we work with families to enhance their clinical care, providing supports for social determinants of health, thus reducing ED utilization. And we had 2 navigators in low-income pediatric practices in Colorado. The next project we felt was really innovative. It was looking at partnering with public health and placing navigators in a WIC office here in Colorado in a high-need area. And the third project was looking at working in our community health clinic, administering a screener and having referrals go directly to navigation to address social determinants of health. So we started with 6 navigators, 3 different projects. Next slide, Erin. So, and since January of 2016, we've grown from 6 navigators in 3 settings to 12 navigators in 9 settings. It has been a great experience to watch the integration of this new team into the care coordination model within the medical setting. In 2018, we had 11 navigators provide support to 5,000 families in those settings, primarily financial assistance, benefits assistance, food insecurity, and assisting in finding primary care providers. You know, and I think that's an interesting thing that we didn't anticipate as being a top need, is if the child is coming in for well child checks and the parent does not have a primary care provider, how does that impact the total health of the child? And we were just intrigued by how many parents do not have health care themselves. And if we help parents provide access to health care for them, does that change the health of the child? So, next slide, Erin. So where do we go next? I think we've successfully integrated the navigators into the healthcare system, and I can't say it was not without challenges. There were a lot of pushback initially about hiring people from the community. How would those individuals integrate into a medical setting? I was asked questions like, do they know how to make decisions? How are they going to work with someone and advise someone and support them when they're community members themselves? So I think we've overcome that. They're now considered indispensable to the healthcare team, but it did take a lot of work. We are expanding into a school-based health center in a low, high-need neighborhood here in Aurora, and we're expanding into an elementary school this year. The other thing we're doing is we know and we're documenting who our partners are. So who are we referring to, and how can we work with those partners to enhance services to our families? The other challenge, and something that we're working on continually, is what is the evaluation criteria for this program? I think if you have an asthma-based program, a diabetes prevention program, I think you can measure outcomes. You can measure how often they go to the doctor, how often they go to the ED, but it is a challenge when you're addressing social determinants of health to determine if you provide housing support, does that have any relationship to health outcomes? Or do you need 10 years to prove that? So we're really struggling with that. We're also using two different data collection systems. We're using a community-based data collection system for our navigators in WIC and in the pediatric practices, and then we're using Epic in the clinical settings. And then fourth is, how do we address this, and how do we look at a value-based payment model here in Colorado? So Kylie, I will be calling you about how you accomplish that. So I feel that it's been very successful in Colorado, and it continues to expand in all types of settings. So that's it.
All right, thank you, Julie. Let me stop my share. Okay, so I'd like to welcome our final presenter for today, Kristen Juliar, who is the director of the Montana Office of Rural Health and the Area Health Education Center at Montana State University. And she helped develop the Minnesota CHW program for Minnesota State Colleges and University, as well as the Montana CHW Training Program. So she's going to share a little bit about their efforts today.
It's a fairly new role for us, and when I got here in Montana about 13 years ago, there really weren't many people using anything that looked too much like a community health worker. But in around 2015, there was a pilot project that was funded by the Federal Office of Rural Health Policy and CMS for Frontier Care Coordination. And it tested using part-time CHWs in critical access hospitals and had great outcomes, and word of that spread quite a bit throughout Montana. And then more recently, a project funded by the Robert Wood Johnson Foundation and CMS, but the Mountain Pacific Quality Health Foundation, was very highly evaluated and structured, and they have really tracked the outcomes from that, and it was very, very successful in using community health workers and care coordination in clinics. And then we have been conducting workforce assessments every few years, and there are people who are doing community health worker type roles in SNAP, senior centers with maternal child health. So there's a lot of things that are very CHW-like that have been going on in the state. We convened, very much like Kylie, a CHW stakeholder group starting around 2015. We had some funding from the Montana Healthcare Foundation, Department of Labor, TACCCT, we made a lot of jokes about that name, grant is a big grant to develop the healthcare workforce in the state. And then we used some of our Area Health Education Center funding, and we used that to create a community health worker curriculum. The interest was really growing. We had one meeting where we actually had to take down the divider walls and expand the room because we had so many people show up to talk about community health workers. So it was getting very exciting in Montana. We used the curriculum consultant Sue Rowe, who also worked with Minnesota to develop their curriculum. And the stakeholders were extremely involved in identifying all the competencies that would go into the curriculum. And it is available on an we're training everybody right now online, but we also have the option to do it in person. These are our modules. They look probably pretty familiar to anybody who's looked at community health worker training anywhere. Kind of how you organize it in a lot of ways. And we have a 25-hour supervised experience at the end. We use the American Public Health Association definition of CHWs. We aligned our curriculum with other national models. We looked at what other people were doing, and the CHW Core Consensus C3 project. I want to call out the Washington Department of Health was really, really helpful to us in explaining how they delivered their training and how they developed it. And so we are in debt to them for their help. And then more recently, we just crosswalked the curriculum with a community paramedicine curriculum, which is, of course, a whole other topic, but I'll explain why we're interested in that. We manage the curriculum and online training through the Montana Office of Rural Health and the Area Health Education Center, which I direct, and that's at Montana State University. We approve the training providers, and right now those training providers are our 3 regional AHEC direct centers. One is located at the Montana Hospital Association's Foundation. They have the MHA Academy. It's an online training system, and they run that. Montana Health Network, which is in eastern Montana, and they also do a tremendous amount of training for their members, and Riverstone Health, which is in Billings, Montana, and they are a very large community health center. The way we pay for training, CHW is an approved training program in a grant that we have called the BWET grant, Behavioral Health Workforce Education and Training Paraprofessional Grant. That is a grant to our office. Organizations sponsor the trainees, so a hospital or a CHC or anybody who wants one is a program is an assisted living program for people with traumatic brain injury, for example. They sponsor the trainees, they pay the upfront cost, and then we reimburse them upon successful completion of the training. If somebody wanted to go through it as an individual, we could accommodate that too, but we're trying to match the training to actual jobs as the profession develops. And we also can pay for, out of our training, the UC Navigator Training Level 1 for people who want a more advanced care coordination training. We have regular courses, scheduled courses. Started kind of slowly, but it's really picking up speed, especially with all the funding for opioids in our state. The community health centers receive supplementary funding for OUD, FCD, workforce development, as did we. And so that's kind of increased interest in training. And we're also training a lot of critical access hospitals, just really all kinds of settings. And then we are developing an add-on module system around that, as Patricia mentioned, that knowledge area. One is geriatrics, which is a big issue in our state, especially in rural areas, and we have funding from the Montana Geriatric Education Center to develop that training. In Montana, Senate Bill 38 just passed a few weeks ago in the 2019 legislative session. It's a bill they've been working on for a long time, and it authorizes community integrated health for EMTs. And there is a state pilot project with 6 communities through the Montana Department of Public Health and Human Services EMS division. In preparation for this, we crosswalked the community health worker curriculum with the community paramedicine curriculum, and I compared all the competencies, and there's very little difference, just some minor things that could be supplemented. And so they're starting a pilot project with these 6 communities, and we'll be training 30 EMTs. I believe they're all EMTs. There may be a paramedic or 2 in there too, starting June 1 in the CHW curriculum, and we're very excited about that. So for more information, we have on our website at healthinfo.montana.edu. If you go into the behavioral health workforce section on that training and our other trainings, And Beth Ann Carter, who is also on this webinar, manages the training program for the behavioral health workforce projects, and she would be a great contact to learn more about anything you want to know. Thanks.
All right, thank you for sharing that, Chris. So we have a good amount of time for questions and discussion. So I'll give our attendees a moment. I don't see any questions coming in yet, but please take a moment to ask any questions of our presenters today. And I have a question actually for Julie. Julie, could you tell us more about the process of hiring these individuals? Because I know there are certain things you were looking for and, you know, really wanted to tap into that insight from the community. So could you talk a little bit more about that process?
Yes, and I would say it's evolved over the past 2 years, Erin. Initially, we came up with a basic position description using several different national resources. We posted the position, we got 185 applicants, of which 80% were not even close to being qualified. And what I mean by that is we required knowledge of the community, we required just a high school diploma, and we were getting applicants for people with masters in social work, healthcare administration. So we really had to take a step back and look at our community partners and advertise through them. And I think we were very successful in getting this right 6 applicants first. So now when we advertise for additional positions, we really now have developed this network of community partners who help spread the word for us.
Thank you. And as you developed the job descriptions, going back to Patty had really mentioned the importance of the role clarity and defining from the other members of the healthcare team or in the WIC office, I imagine other members of that team. How have you worked to really ensure that those roles are laid out?
You know, we met with each group separately since we were in 3 settings and really came up with process maps outlining the roles from the very beginning. Again, there were, I think in our community settings, especially, there were a lot of challenges. For example, in WIC, you know, are there concerns that the navigator is taking over some roles and responsibilities of the WIC educator? I think in the clinical setting, actually, it was a little bit easier to do that role clarity and talk about the integration into the care coordination team.
Thank you. And we just had a question come in for you from Chantrice Jones. Julie, can you speak more to the decision of why the CHW shouldn't have an advanced degree?
You know, we really felt it was important to start with people from the community. We do have people on the team that out of the 6 original hires, 2 had bachelor's degrees, but we really wanted people that had experience and perhaps this was their first opportunity at employment. So not only how can we help them provide the best services to our families, but how can we help them in their path of professional development? And we take both of those responsibilities on equal footing. Out of the 6 original, for example, 2 have degrees and 3 of the remaining 4 are now going back to school. So, you know, it's an equal kind of partnership of how we do that and our role and responsibility.
Can I ask a follow-up question?
Yeah.
Could you describe what kind of job aids or tools or the infrastructure that was developed to support the community health workers, and also to alleviate the concerns that some of the providers might have had about, you know, having an unlicensed person in the role?
Yeah. Well, first, to be quite honest, I went to Patricia and Erin and asked them to help develop the initial training program. When the team first started, we actually called them community health liaisons, and it didn't seem quite as that the Patient Navigator Training Program was quite right for them. And so I worked with Patricia and Erin to develop a curriculum for that. We did a lot of in-service with each of the clinical teams and community teams about the roles of the navigators, and really helped clarify any questions or concerns up front. We probably spent 3 to 5 hours with each of the individual groups talking about roles and responsibilities.
I'm wondering, from your perspective, Chris, the majority of people that you see coming through your program, what is their educational background?
I don't have that information. Beth Ann may, but I really couldn't tell you what their educational background is.
And I wanted to backtrack one moment also. We have a distinction here at Children's. We have family navigators that work in the main hospital, and those individuals, you know, have social work degrees, masters in social work, you know, from a wide range of fields. But we were just strongly committed community health navigators who are going to be working in the community, looked and had similar experiences.
Yeah, this is Kylie. I guess just building off of that as well, from just some of the work that we've heard happening within South Dakota, within the Sanford Health System. I would say very similar to at Children's, you know, we're hearing that, you know, they have designated a person to address some of those social determinants of health within the hospital itself, in one of our largest metropolitan areas. And then we know of another smaller facility in a smaller community that took more of the community member approach, and they're working more closely with other community resources and more of the lay person, where the individual within the larger health system has a social work degree and has those additional skills to do that work. So we're also seeing that in South Dakota, where there's, you know, different types of roles doing similar type of work, but very understanding their lanes too, of what they like they can do and can't do. And there's benefits definitely to both. And I think it's just, as an organization, thinking about what your needs are and the level of expertise that you are needing for the type of things you're wanting to address, and realizing that it looks very differently in probably every facility within our state, you know, and thinking about what their highest need is and how best to go about it.
I have one other point. We've recently come into some challenging situations in the WIC clinic. A year ago, we integrated behavioral health specialists into that setting to work along with the navigators. It's a high immigrant and refugee population. Unfortunately, the behavioral health individuals are only there 2 days a week. But what we're finding is that when families are asked about behavioral health issues, if the navigator is the first point of contact, the family has an expectation that they're going to get that type of support. The navigators aren't trained to provide that type of support, so we've had some challenges there.
And I think Beth Ann did post that we have quite a variety of people. Some have degrees and some have high school diplomas. And I know we've had one who worked with a project from Mountain Pacific. He actually had a background as a medic in the military, and that was a really valuable experience. He was working in a kind of a high level of care coordination and had some great skills. So I think it does too depend on if they're really putting in as care coordinator roles, or if they're more kind of the outreach in some of our rural facilities to make sure that the elderly population is getting to their appointments and can get their medications and things like that.
Yeah. I think the other thing I didn't point out is the community health navigators, different than the family navigators in the main hospital, is that they actually do community support. So they'll go out to Social Security offices, they'll go out to food banks with families and do home visits. And I think that was another critical piece of having people representative of the community doing those tasks with families.
Thank you for mentioning that home visitation piece, Julie. I was wondering, Patty, would you like to talk a little bit about the important training that is required if you are having this role do the home visitations?
Yeah, definitely. So certainly situational awareness is a key part because we want to make sure that our staff are safe and have a way to assess for safety, or there are other strategies that can be used for home visiting, as such as pairing them up and contact with the supervisor. But so that's an area. Also, whenever we train lay health workers or the unlicensed staff, there's always a emphasis on professional boundaries because the community members go into this line of work in order to help their community, help families. And so being very clear, how far you can go, and also at what point is that assistance disempowering. So how to be very careful about doing too much, for example, for a patient or a community member. So a lot of discussion needs to be made around or had around and what is empowering and what is disempowering, what are professional boundaries, and how to stay within your lane, as other speakers have mentioned. So that in addition to situational awareness, I would emphasize.
And we found it really interesting. We thought the number of home visits would be much larger. It's only running about 3% of the individuals they're working with, and primarily individuals who are non-English speakers. So yeah, it's a much smaller number than we thought it would be.
Yeah, some interventions will meet with individuals at community sites rather than the home. Not everyone actually wants someone to come in, and so for example, we've used library meeting rooms or community rec centers in order for the person to feel comfortable and it's a less intimidating environment than, say, the community health center, but they don't also have to worry about having someone in their home as well.
Yep.
We did have one more question come in for Chris. Can you share more on why the expectation, or what the expectation will be of the Community Integrated Health EMT, and how the additional CHW training will expand their roles?
Yeah, they submitted applications on what they expected the community integrated health people to do, and it does vary by community. It's designed to address health needs in the community. So some will be kind of enrolled with the program where they get regular checks for conditions related to their health, and others will be combining between their EMT role, doing CHW type work where they're just assigned to care coordination or to check up on people or to help them get to their appointments, arrange transportation. And in one community where they've been piloting this already, they also work with the school, and they do a program in the mornings where they're there working with school kids on a regular basis to decrease bullying and other issues in the school. So it will depend on what the community wants to accomplish.
Wonderful, thank you. Well, I'll give it one more last call for questions because we're just about out of time. All right, everyone's good. Well, after we conclude the webinar, you will receive a pop-up link to a survey. It shouldn't take you more than 2 minutes, and we really appreciate your feedback. And it will give you also a chance to indicate what you would like to see from future webinars. And I will hand it over to Kylie if you would like to say any last words or final thoughts.
Yes, just thanks again for everyone for joining today. I hope you guys learned something new. And like I had begun our conversation at the beginning of this webinar, that really this is just the first step, but lots more to come from the Department of Health and the Medicaid State Plan program. And I'm open to talking more with any of you about the work that we're doing within the Department of Health around community health workers. And thank you to our states, our presenters today, for sharing their knowledge and their experiences with us today. Definitely very exciting on what you're doing around community health workers and how you're utilizing them within your state. So thanks again, and look forward to working with you all in the future.